the renal cell carcinoma. Renal cell carcinomas mostly occur in adults, and when occurring in children, a high percentage belong to the MIT family translocation types. And RCC is associated with smoking and high blood pressure. Conditions that may be complicated by RCC are the following: von Hippel-Lindau disease, acquired cystic disease of the kidney, adult form of polycystic kidney disease, Burthoff tube syndrome, hereditary leiomyomatosis and RCC syndrome, hereditary paraganglioma syndrome, tuberous sclerosis, neuroblastoma, Beaton hematoma syndrome, hereditary papillary RCC syndrome, and hemoglobinopathy. So what are the different RCC subtypes? Clear cell renal cell carcinoma, papillary RCC, multilocular cystic renal neoplasm of low malignant potential, chromophobe renal cell carcinoma, clear cell papillary RCC, mid-family translocation RCC, collecting duct carcinoma, fumarate hydratase deficient RCC, which is hereditary leiomyomatosis and RCC associated RCC, renal medullary carcinoma, tubulocystic carcinoma, mucinous tubular and spindle cell carcinoma, acquired cystic kidney disease associated RCC, succinate dehydrogenase deficient RCC, eosinophilic solid and cystic renal cell carcinoma, and finally the RCC unclassified, and some other types. So clear cell RCC, it forms 65 to 70% of all renal cancers. It is centered on the cortex, and in 5% of the cases it is multiple, and it is clear because of the accumulation of glycogen and lipids. So ISC for low molecular weight cytokeratin and EMA can highlight in some difficult cases, and it can undergo sarcomatoid and rhabdoid transformation. And a very important feature is the stroma is not desmoplastic. So when you see desmoplastic stroma, you should think of collecting duct carcinoma or urothelial carcinoma. And it is keratin and EMA positive. Co-expression of keratin and vimentin is the rule, a feature not present in normal tubular cells. CD10 positive, carbonic anhydrase 9 positive, RCC marker positive, PAX2 and PAX8. With current antibodies, PAX8 has a higher sensitivity. CK7 expression is typically rare in clear cell RCC. So what is the differential? Adrenal cortical carcinoma, clear cell RCC is negative for inhibin, melanoin and SF1. Clear cell carcinoma of the ovary, clear cell RCC is negative for keratin, 34 beta E12 and CK7. Clear cell carcinoma of the thyroid, RCC is negative for thyroglobulin and TTF1. Mesothelioma, RCC is negative for calretinin, mesothelin and CK56. Genetic aspects can be investigated by conventional cytogenetics, PCR, FISH, microsatellite analysis, single nucleotide polymorphism, microarray or sequencing techniques. Most cases of clear cell RCC is alteration of VHL tumor suppressor, either by terminal deletion of the short arm of chromosome 3 beginning at 3p13 or silencing through promoter hypermethylation and somatic mutation. So this 3p alteration does not characterize other types of RCC. Its detection could be used in the differential diagnosis. However, this is rarely done because of the different possible modes of VHL alteration. While the VHL gene on 3p25-26 is typically implicated with the inactivation of both the copies, other tumor suppressors on 3p may also play a role, such as KDM6A, KMM5C, ZD2 and PBRM1. Mutations in BAP1 have been associated with high-grade tumors and poor outcome. The VHL gene product is required for degradation of HIF1 alpha, hypoxia-inducible factor alpha. With the loss of the VHL protein in clear cell RCC, HIF1 alpha accumulates, resulting in the activation of a variety of hypoxia-inducible genes and increased production of VEGF, PTGF, TGF-alpha, GLUT1, metalloproteinases, and erythropoietin. Furthermore, the AKT-mTOR pathway can also affect the HIF-1 alpha, hence mTOR normally promotes translation of HIF-1 alpha. So targeted therapies may therefore utilize tyrosine kinase inhibitors for VEGF receptor and PTGF receptor, such as sunitinib and sorafenib, inhibitors of mTOR such as temsirolimus, and antibodies targeting the VEGF, bevacizumab. Germline loss of function mutations of the VHL gene on chromosome 3p are associated with hereditary RCC, pheochromocytoma, hemangioblastoma of the CNS, retinal angioma, and renal cysts. The VHL protein is a component of the ubiquitin ligase, a type of protein complex that covalently links ubiquitin chains to specific protein substrates, thereby promoting their degradation by the proteasome. A critical substrate for the VHL ubiquitin ligase is the transcription factor HIF-1 alpha. So the VHL gene is present on 3p, as you can see here, the VHL gene on the short arm of the chromosome 3. In the presence of oxygen, HIF-1 alpha is hydroxylated and binds to VHL, leading to its ubiquitination and degradation. In hypoxic environments, the hydroxylation reaction does not occur, then HIF-1 alpha escapes recognition by VHL. As a result, HIF-1 accumulates in the nuclei of hypoxic cells and turns on many target genes, including genes encoding the growth angiogenic factors such as VEGF, PTGF, GLUT1, and several glycolytic enzymes. Loss of function mutations in VHL also prevent the ubiquitination and degradation of HIF-1 alpha even under normoxic conditions, and are accordingly associated with increased levels of angiogenic factors and alterations in cellular metabolism that favor growth. So in this, normally in the presence of oxygen, HIF-1 alpha is hydroxylated, and when hydroxylated it binds to VHL. VHL will cause the ubiquitination of the H1F alpha and leading to its degradation. So two steps, either the oxygen should be lost or the VHL should be lost for the HIF-1 alpha to get activated. So if oxygen is not there, HIF-1 increases, turn on the genes for VEGF, PTGF, GLUT1. Or secondarily, if there is loss of VHL, this step will not occur, so HIF-1 alpha will increase, turn on the genes.